The urinary system consists of the two kidneys, which have the role of producing urine, and the urinary tract, which includes the two ureters, bladder and urethra, that transport and eliminate urine outside. Between the kidneys and the ureters is a funnel-shaped formation often referred to as a basin that collects the urine formed by the kidneys. The most common kidney diseases are nephritis, also known as glomerulonephritis, lipoid nephrosis, and kidney stones. The inflammation of the pelvis is called pyelitis, and if the infection also includes the respective kidney, it is termed pyelonephritis. Bladder infection is also known as cystitis or pylocystitis if it is complicated by pelvic infection. Urine serves as a mirror of the good functioning not only of the urinary system but also of all the organs of the body, reflecting their health in the quantity and quality of urine. Conversely, the disease of the urinary system is felt by the whole body. This is why almost no patient is recommended a urine test in addition to other tests, as it is simple to collect and analyze. Alongside the analysis of urine and blood, the diagnosis of diseases of the urinary system is greatly aided by urological and radiological examinations. Acute glomerulonephritis is a kidney disease that occurs after a recent microbial infection, most often following a streptococcal infection such as angina, scarlet fever or erysipelas, a fact more frequently observed in children and adolescents. An allergic side of the disease is also acknowledged. The disease begins suddenly with chills, fever, headache and saddle pain, lack of appetite, fatigue, swelling of the face and legs, known as edema, vomiting, and a decrease in the amount of urine, which, due to the presence of blood, appears dark in color. If the patient's blood pressure is measured, it is found to be elevated, despite their young age. When treated correctly in the hospital, the disease can be cured in 3 to 5 weeks, preventing the transition to acute renal failure or chronic glomerulonephritis. Laboratory analyses help clarify the diagnosis. For instance, the examination of the secretion collected from the throat can isolate the streptococcus if no antibiotic treatment was done before. In the blood, the increase of anti-streptococcal antibodies can be highlighted with the ESLO reaction. Rarely alpha, beta, and gamma globulins are increased. White blood cells are elevated and red blood cells are moderately decreased. In a more advanced phase, an increase in the concentration of urea, uric acid, chlorine, sodium, and potassium is found in the blood due to their retention in the body, while these substances are low in the urine. The urine contains blood and albumin, and under the microscope, numerous red blood cells, leukocytes, granular cylinders, hyaline, hematic, and leukocytes are observed. The ADIS test reveals tens and hundreds of thousands of red blood cells per milliliter and per minute. The disease is a result of various nephritis, not cured for 6 to 12 months, and nephrosis. It primarily affects adults who suffered from kidney disease during childhood. For many months and even years, the patient might appear healthy, neglecting frequent streptococcal infections, especially of the throat. The disease begins slowly, often being suspected due to the discovery of high blood pressure. Over time, the patient experiences general weakness, frequent thirst, followed by the elimination of large amounts of urine, particularly at night. Ultimately, the destructive processes of the kidneys lead to renal failure, a phase in which the urinary system can no longer cope with the body's normal needs. The urine becomes diluted with a very low specific gravity of around 1010. Because the kidney's ability to concentrate urine decreases, the concentration of urea, creatinine, uric acid, and phosphorus increases while calcium in the serum is low. Albumin is constantly present in the urine, and microscopic examination shows the presence of white and red blood cells, urinary cylinders, which are hyaline and granular. At the origin of this syndrome are countless other diseases caused by infections such as glomerulonephritis, tuberculosis, malaria, and syphilis, diabetes, blood diseases, heart failure, and poisoning from substances like bismuth, mercury, gold, and pesticides. The main symptoms include edema of the face and legs, which then covers the whole body, and a prolonged febrile condition ranging from 38 to 39 degrees Celsius. Additionally, the patient experiences headache, back pain, nausea, vomiting, fatigue, and a generally poor condition. Blood analysis shows a marked increase in total lipids, cholesterol, and triglycerides, a decrease in blood proteins, an increase in alpha-2 globulins and beta globulins, with a decrease in gamma globulins. The fibrinogen level, as well as the erythrocyte sedimentation rate, show much higher values. These protein disruptions also test positive with the thymol reaction, the Gross reaction, and the Takata-Ara reaction. The urine is dark and milky due to the presence of fat and is produced in small quantities with a high density of more than 1030. Urinalysis shows an increase in albumin due to the massive loss of protein from the blood. Microscopic examination finds numerous hyaline, granular, epithelial, hematic and leukocyte cylinders, fat droplets and cholesterol crystals. Failure to treat the disease in its initial stage predisposes the patient to chronic renal failure. Inflammation of the bladder is called cystitis. The disease is caused by different microbes such as Colibacillus, Proteus bacillus, Klebsiella, Staphylococci, Streptococci, Enterococci, and so on. The infection starts either from below, from the urinary canal, or from above, from the kidneys. In the case of tuberculosis at the level of the kidneys, the Koch bacillus that reaches the urinary bladder can determine a tuberculous cystitis, and some toxic substances or drugs that are eliminated in the urine, like bladder stones, can irritate the bladder and cause cystitis. The disease is favored by colds, bladder stones and polyps, some traumas, allergic conditions, constipation, and so forth. The main symptom is burning, stinging pain in the lower abdomen. The patient urinates often, and at the end of urination the pain is accentuated. Infectious cystitis is accompanied by chills and fever. The urine is in larger quantity and has a dark color if it contains blood, or it is cloudy if it also contains microbes. Urine analysis reveals albumin, red blood cells, leukocytes, and with the help of urine culture, the causative microbe is discovered. To relieve the pain, the patient will stay in bed and take algocalmin or paracetamol, as well as antispasmodic drugs, preferably in the form of suppositories. Warm compresses on the abdomen and warm teas, especially diuretic tea, also relieve pain. Antibiotics will not be taken before collecting urine for urine culture, as they destroy any microbes that need to be analyzed. Based on the result of the antibiogram, the doctor will recommend the most active antibiotic. Renal basin infection, acute pyelitis, is less often located at this level. It extends either higher, at the level of the kidneys, pyelonephritis, or lower, at the bladder. Also, in most cases, the infection comes from an untreated cystitis and usually affects only one pelvis. The microbes that cause pyelitis are the same as those mentioned for cystitis. The disease begins suddenly with chills and high fever, around 39 to 40 degrees Celsius, sweating, saddle pain in the affected part, fatigue, and a general bad condition. Urination is very frequent but in small quantities, sometimes just a few drops, and is accompanied by pain and stinging, which also shows the suffering of the urinary bladder. Urine is cloudy and reddish when mixed with blood, which is why it always contains albumin. Microscopic examination of the urine reveals numerous leukocytes, red blood cells, and bacteria, most often bacilli. The bacteriological examination, or urine culture, shows the presence of bacteria such as Bacillus coli, Proteus bacillus, Klebsiella, Piaceanic bacillus, Staphylococcus, Enterococcus, Streptococcus, and others. The Addis test reveals a large number of red blood cells and leukocytes. It's an infection that involves both the kidney and the pelvis of that part at the same time. The germs that cause the disease are the same that are also found in acute dermatitis and that often climb up the urinary tract from a bladder infection. Less commonly, pyelonephritis is caused by the tubercle bacillus in the presence of pulmonary tuberculosis. The disease begins suddenly with chills, fever, especially in the evening, headache and pain in the back, next to the diseased kidney. Added to these are pains and stings when urinating, dryness of the mouth and a general malaise. The infection occurs more frequently in women, especially in pregnant women, the elderly, children, those with urinary calculosis, prostate enlargement, narrowing of the urinary canal, diabetes and constipation. Urine is in small quantity, cloudy or reddish, and contains blood, albumin, cylinders like leukocytes, granulosa, hyaline, epithelial, and bacteria. The Addis test reveals a large number of leukocytes and red blood cells, and the alkaline pH can indicate, in addition to the existence of an infection with common microbes, the absence of a tuberculous infection. In some cases, the urine has a bad ammonia smell. The disease evolves with periods of improvement and aggravation, and if not treated correctly or treated with antibiotics to which microbes quickly become resistant, it can turn into chronic pyelonephritis. Uroculture detects the microbe that caused the disease, and performing the antibiogram gives indications regarding the antibiotic sensitivity of those microbes. Infection of the kidney with the tubercle bacillus occurs within tuberculosis of the lungs or other organs. The beginning of the disease can only be appreciated when the infection becomes chronic. The patient shows the general signs of tuberculosis: low-grade fever with sweats, weakness, fatigue, anemia, and lack of appetite. Urinary symptoms appear later and consist of back pain, frequent urination, and stinging when urinating, indicating that the infection has reached the bladder. The lack of cure of the disease after treatment with usual antibiotics argues for tuberculosis of the urinary system. Urine is acidic, cloudy, and contains leukocytes and red blood cells and albumin, but in most cases urine culture does not reveal common microbes. During the microscopic examination of the urine, red blood cells, leukocytes, and tubercle bacilli are found. Through urine culture and urine inoculation in guinea pigs, the respective microbes can be isolated, specifying the diagnosis of the disease. Tuberculosis of the kidneys will be suspected in a former patient of pulmonary tuberculosis, even if the disease has apparently been cured. Renal lithiasis, renal calculosis, or kidney stone consists of the formation of urinary stones in the kidneys. There are many causes of urinary lithiasis: excessive diet in meat or grains, oxalic acid, calcium, liver diseases, obesity, urinary infections, genetic causes, and more. The mechanisms of stone formation consist in the precipitation and agglomeration of mineral and organic substances from the urine into solid matter in the form of sand or pebbles. The disease occurs more frequently in men aged 30 to 50. According to the chemical nature of the substances in the urine, stones can be calcium oxalate, uric acid, phosphate, calcium carbonate, or a combination of these substances. These stones, formed in the kidneys, at first very small, grow and enlarge by depositing new layers of urinary material. But most stones migrate from the kidneys and pelvis to the ureters, ureteral lithiasis, and the bladder, vesical lithiasis. Urinary lithiasis produces two major complications: urinary infections such as pyelonephritis or cystitis, and renal colic, with incomplete or complete blockage of the urinary tract. Apart from the mentioned complications, it's very difficult to suspect urinary calculosis. Even urine analysis cannot reveal important changes, because if urinary substances, chemical components of stones like uric acid, oxalate, and calcium phosphate, urates, are found under the microscope, they're also found normally. Only a radiological examination can detect a urinary calculus earlier. But the superinfection of calculosis produces the same symptoms and urinary changes as in the case of pyelonephritis and cystitis. When a kidney stone has migrated from the kidney and entered the ureter, which is very narrow, it contracts and tightens to remove the stone. This contraction, due to the irritation of the ureter by the calculus, immediately gives rise to colic pain. Often the pain comes on suddenly, a few hours after physical exertion, after a car or cart ride, after a jump, which causes mobilization of the calculus, or even without any obvious cause. The pain is strong, sometimes unbearable. The patient shakes, moans, takes different positions, sweats, is pale, may have nausea and vomiting, and the feeling of urinating often. Usually the pain is localized on the side with the stone, but it can also radiate to neighboring regions, back, abdomen, and genitals. These symptoms, which last for several hours, sometimes a day or two, subside as the stone is pushed out to the bladder. The painful attack can be repeated if the stone has not been removed, or if it is another stone. In many cases, the urine is small in quantity and dark in color due to the presence of blood, as a result of bleeding of the urinary tract after contact with the rough and gritty calculus. In most cases, the presence of blood can be detected by microscopic examination. Uric acid, calcium oxalate, calcium phosphate, and urate crystals can be found in the urine, but it is not mandatory. When kidney stones are complicated by infection, leukocytes and bacteria are found in the urine. Renal colic can recur after months and years if the kidney produces other stones. If a stone does not pass spontaneously, then it is removed through a surgical operation to prevent the loss of the kidney. For calming down the pain, An antineuralgic like algocalmin or paracetamol tablets or suppositories is recommended. And to combat the nervous spasm of the ureter, put compresses or warm poultices on the painful part of the back. Then the patient should drink a lot of fluids in the form of hot teas, up to 2 liters in 24 hours, with the aim of forcing the removal of the stone or sand.